I know how stressful it is to look after pregnant patients who are having heavy bleeding because we deliver a lot of babies in our hospital. Roughly 6,000 babies are delivered in our hospital a year, and that means our emergency department sees a lot of pregnant people at various stages of pregnancy. And occasionally we have patients with massive hemorrhage. And I think it's great and important to have an approach to how we look after these patients. But I'm going to take a step back first and look at the evidence. We know that obstetrical hemorrhage is one of the leading causes of maternal morbidity and mortality worldwide. And there's not a lot of evidence that informs what we do when we look after these patients. And I did want to highlight one trial that was informs how we look after these patients as it relates to tranexamic acid. And this was the World Maternal Antifibrinolytic trial, which is called the Woman trial. It was published in the Lancet in 2017. And I highlight this trial because it was such a huge undertaking. So it included 193 hospitals in 21 countries that are both mostly low and middle income countries and enrolled over 20,000 participants. And some of the things that were notable about this trial as they relate to our practice in emergency medicine was that it was a pragmatic trial. So the providers were allowed to use their judgment as to whether or not a patient qualified to be enrolled in the trial. And if the provider deemed that they had postpartum hemorrhage, then they were enrolled in the trial. So postpartum hemorrhage meaning hemorrhage immediately after birth. And patients received either tranexamic acid, 1 gram IV, or placebo. And if the hemorrhage continued, they received that dose again in 30 minutes. And what they found was that patients who received tranexamic acid had decreased risk of maternal morbidity and mortality. Now, this is one of the few trials in this area, and we really have to extrapolate our management of all pregnancy-related hemorrhage to this trial. And so there are some limitations to doing that, but it is one of the few trials in this area. For any patient who's pregnant coming in with vaginal bleeding, and in particular heavy vaginal bleeding, the approach is the 4 T's. So those 4 T's are tone, trauma, tissue, and thrombin. And by tone, we mean uterine tone. So patients that lack uterine tone or uterine atony are at increased risk of bleeding. Patients that have trauma to the cervix or the vaginal canal can have vaginal bleeding. And retained tissue is a very common cause of bleeding in the emergency department setting. And patients with underlying coagulopathic disorders or acquired coagulopathic disorders are also at risk of pregnancy-related hemorrhage. And what we see in the emergency department is that patients come to the emergency department at times when they don't otherwise have access to ambulatory obstetrical care. And so we see patients in the first trimester, and then we don't see them again much in that third trimester to nearing delivery because they often go to labor and delivery floors. And then we see them again in the postpartum period, usually between 1 and 10 days after their hospital discharge. So we don't see the third trimester or delivering patients very often in the emergency department. But it's important for us as emergency department providers to really be prepared to care for all pregnant patients who are coming in with bleeding. And it's important to think about these time points because your causes are going to be informed by when patients are coming in presenting with bleeding, and also their ongoing management of the bleeding will be informed by the period of pregnancy and gestational age that they are. So my first population that I'm going to talk about today is those who are delivering and are having immediate postpartum hemorrhage. So we don't see these patients very often because they usually make it to the labor and delivery floor. So in our emergency department, we do an in situ simulation of maternal postpartum hemorrhage on about an annual basis because it's not a patient population that we see. They have very specific management, and it's when we don't practice this in our environment, we often can make mistakes when they come in the real world setting. So we do simulate this in our department, and by doing so, it helps us know where our gaps are in our care and prepares us for scenarios, real life scenarios, where patients are delivering in our department. So we simulate an EMS patch coming in, saying that a patient is coming in, we'll say, for instance, a 32-year-old G1, P1 who was in the process of delivering in the ambulance, so a precipitous delivery. And EMS calls in saying that not only did the patient deliver, but now is experiencing heavy bleeding. And so if you receive that patch into your emergency department, you want to prep your room like you would prep a trauma. So thinking about what equipment you're going to need if a patient's having massive hemorrhage. So going have it priming your lines, thinking about whether you have a level 1 infuser, and then also identifying and knowing where your postpartum hemorrhage medications are. And I'll talk about our postpartum hemorrhage med kit that we have in our department. And also notifying obstetrics, figuring out whether or not they're in a cesarean section, can they come down, notifying them that they have a pregnant patient coming down, and your NICU potentially, if you have a NICU available, or a pediatric provider can help care for the infant, and finally notifying your blood bank in the case of needing a massive transfusion protocol. So this is our team. We have successfully delivered a baby in the emergency department here, but in this scenario, the patient has ongoing heavy vaginal bleeding. And so in this simulation, we often involve multiple teams, just like it were to happen in the real world setting. And your approach to this patient, in addition to your ABCs and resuscitation approach, like IV, O2, and monitors, are also 4 T's. So TXA, tone, transfusion, and temperature. So let's talk a little bit about those. So TXA, as we mentioned, is one of the few evidence-informed medications at our disposal. So 1 or 2 grams of TXA administered IV would be appropriate in a scenario. And then we're going to focus on tone. And by tone, again, I mean uterine tone. So we would start by applying fundal massage to increase the uterine tone to decrease the amount of bleeding. And when someone is performing fundal massage, it's not a gentle massage of the fundus. It's actually something that you'll need to verbally tell your patient why and what you're doing, because it is uncomfortable to apply fundal massage. It's right at the fundus, and you'll see a provider usually putting a fist into the fundus and providing a very forceful massage to help clamp down on those uterine vessels. And then in addition to fundal massage, we'll be using medications to increase uterine tone. And I'll talk a little bit about those in a moment. And then we want to make sure that your patients are getting appropriately transfused. So not just replacing these patients with crystalloid, but replacing their losses with blood. So similar to a trauma, we want to focus on the replacement of blood products in these patients, and also maintaining their core body temperature, because you don't want to induce a coagulopathic scenario, which will make bleeding worse. So let's focus in on tone for these patients. So these medications are ones that we don't use very frequently. And so in our department, we've created, like other departments, a postpartum hemorrhage kit that can be stored in the refrigerator, and then also grabbed when needed on demand. So this is these are the medications and the information sheet that we have in the kit. And what you'll notice is that all of these medications, quite conveniently, are administered in different ways and have very different doses. And so it's almost impossible for us as emergency department providers who almost never use these medications other than TXA to remember all of these different doses and routes. And so we have a cheat sheet that was developed in our department with our pharmacist to make sure that we're administering these medications safely for patients and know what the relative indications and contraindications are. And so we'll go through some of these together. So TXA, we all know, it's one we're very familiar with. It's not a ureter tonic, but it's in our postpartum hemorrhage kit. The next one is oxytocin, and this is given as a 40-unit IV infusion. Ergonavine is next. And again, these don't have to be in a particular order. This is just how we have them set up in our department. This is an IM dose. Carbaprost is 250 micrograms IM, and misoprostol is either sublingual or more frequently used as a rectal per rectum dose. Now, all of these medications can induce nausea. They often will make people feel very nauseous quickly. So make sure that you have an antiemetic on hand for these patients. And then several of them have some relative contraindications. So the ergonavine, for instance, can't be used in a patient who has concomitant preeclampsia or hypertension. And in patients with coagulopathy or major renal or hepatic dysfunction, carbaprost is also not able to be used. Now you'll see all over the bag that there's this hazardous drug warning. The reason for this, these are not teratogenic medications. It's because they can induce increased uterine tone in a person if they get it on their hands. And so it's not the time that you want to learn about your team members' pregnancies. And so you want to make sure whoever is handling these medications is wearing appropriate protective equipment, like gloves, a face mask, and a gown to ensure that it doesn't get on their hands in the case that they happen to be pregnant. Now, if the situation is not improving, then we need to think about our rescue methods for tamponading the bleeding uterus. And so the Bakri balloon is the type of balloon you'll see here that's in the yellow square that is the preferred device for this purpose. And we in emergency medicine love to MacGyver things, but the myth that you can insert a Foley into the cervix and decrease uterine bleeding is in fact a myth. And you can see why, because of the difference in size of the balloon. It really doesn't provide adequate involvement of the uterine wall there because it's too small if you use just a Foley catheter. So particularly in rural settings, having a Bakri balloon available can be a very helpful rescue maneuver and equipment. I only include this slide, which is when to initiate a massive transfusion protocol, and is a reminder to do so. So most emergency departments and hospitals in Ontario have a massive transfusion protocol, certainly large to medium to large volume emergency departments. And it's such that you don't have to remember the order of giving packed red blood cells and platelets and FFP for patients who and coagulation factors. When you already have a lot going on in these patients, it just helps get all of the things that patients need when they are having a massive hemorrhage. So let's move on now to the patient population that we don't see very often in the emergency department, which are patients who are experiencing bleeding between 20 and 40 weeks pregnant. So these are patients that often go to the labor and delivery department, certainly in hospitals in Canada. And the 4Ts really don't apply to this population. We divide the causes of bleeding between 20 and 40 weeks between painless and painful causes of bleeding. So those that are painless are placenta previa and vasa previa, whereas those that are painful are placental abruption and uterine rupture. And our goal in these patients is to provide maternal hemodynamic support, so ABCs, IVO2 monitors, transfused where appropriate, but really we're getting these patients to definitive obstetrical care. And so while there are pregnant between 20 and 40 weeks, it's really about getting them to definitive obstetrical care. So let's focus on our next population, which are those patients who present in the delayed postpartum period. And these are commonly encountered in our emergency department because patients are discharged from hospital usually within 24 hours after a normal spontaneous vaginal delivery or up to 72 hours after a C-section in our healthcare systems. And so they often will have those delayed hemorrhages at home, which means they then present to the ED. And so these are ones that we should feel very comfortable managing. So the most common cause of bleeding in this population is retained tissue. And that really guides the management. Now, they do still have a gravid uterus that in the first 1 week postpartum would still benefit from increased uterine tone, but usually uterine tone is not the cause of the bleeding. And so for these patients, the most common cause is the retained tissue, often retained placenta. Now, I bring this slide to your attention because in addition to causing bleeding, retained tissue, retained placenta can cause patients to have postpartum endometritis, which can present as sepsis. And so all of a sudden, not only do you have a hemorrhaging patient, but you also have a septic patient, and this can become a cascade into coagulopathy and DIC. And so these patients, we advocate for early antibiotics if there are signs of infection. So for postpartum endometritis, it would be Clinda and Gent, and that's what gentamicin, which is what I'm highlighting here. But just please be mindful that these patients are at risk of both hemorrhage and postpartum endometritis when there is retained tissue. Now, before finishing with this patient population, when a patient has retained tissue, definitive management usually will require the tissue being removed. So if a patient is hemorrhaging, that means they're likely going to need to go to the OR. If they have a bit of spotting and retained tissue and pain, then the treatment might be medical. But for the purposes of this talk, where we're talking about hemorrhage, these patients will need to go to the OR, and obstetrics needs to be involved early in their care. Now, the most common patient population that we see in Canada in the emergency department who are pregnant are patients in first trimester, and they will generally present with massive hemorrhage at times when they are miscarrying. And this is a population that we see very frequently, and both late first and early trimester, early second trimester losses will have very heavy bleeding at times in our department. So the main cause of bleeding in these patients are the retained tissue. And the management of these patients is really focused on that. Now, of course, you can have patients who have undiagnosed underlying coagulopathies, but the most frequent cause is retained tissue, as opposed to not having enough uterine tone. Now, oftentimes when I see these patients being managed and discussed with learners, they'll want to reach for those postpartum hemorrhage medications like the ureterotonic medications like oxytocin and all of these other medications. When you have a uterus that's less than 12 weeks, it is very unlikely to be, uterine tone is very unlikely to be the cause of bleeding. And you're essentially just going to give these patients side effects by giving them medications like carboprost, ergotamines, and misoprostol for the purposes of controlling bleeding. So we really don't reach for those postpartum hemorrhage medications in these patients. We are really reaching for our physical exam to help with the management of the bleeding. So these patients, once you have IVs and monitors established and you provide appropriate pain medication in the setting of bleeding, a heavy first trimester bleeding with pain, we want to do a very thorough physical exam and speculum exam to help remove the tissue from the cervix. And it's important to talk with your patient through this process about why you're doing a speculum exam. It's an uncomfortable exam, but reassuring them that it will help decrease their amount of bleeding, help them feel more comfortable, is an important part of that communication with your patients. So the supplies here that I want to make sure that you have with you. So when you're performing a speculum exam on a patient who's having hemorrhage related to a first trimester or second trimester loss, you want to have a large speculum. You also want to have a stack of 4x4 medications. This is a 4x4 gauze. This is a sterile procedure, so these should be sterile. And then ring forceps here are a helpful device, but I think emphasizing that this type of speculum exam should be positioned well with good lighting and team members who can be there to help hand you things is really important, because you want to have excellent visualization of the cervix to be able to remove both clots and tissue from the cervix, because in doing so, it almost immediately will help decrease the bleeding, and it will also help decrease the vagal tone that is stimulated by tissue being stuck in the cervix. So when tissue is stuck in the cervix, it will make somebody clammy. They can go bradycardic, they can go hypotensive. It can make it feel really unwell, and they can look unwell. And just by removing the tissue, you can almost ameliorate your situation immediately, and that makes the patient feel better as well. Now, if you don't see anything in the cervix, or the patient continues to bleed despite you pulling tissue from the cervix, then these patients need to go to the OR, and you need to advocate for these patients to go to the OR if they continue to have heavy bleeding in your department, because these patients can have massive blood loss that can result in transfusion, and in some situations in death. But also, I think it can create more unnecessary morbidity, where people have to have weeks to months of recovery because they had massive blood loss secondary to a first trimester loss. Patients that experience pregnancy loss at all stages are at very high risk of PTSD, moderate severe anxiety, and depression. If you measure these symptom scores at a month, these rates are quite high, and it takes up to a year for patients to have full psychological recovery. And so when we are caring for patients in these scary situations where they're having massive hemorrhage, it is most certainly scary for them as patients. It's scary for us as providers, but we need to be very attentive to the language that we're using around pregnancy loss, because just helping patients understand the things that you're going to do in language that they can understand, that is compassionate, can help them in their recovery and prevent them from being exposed to traumatizing scenarios. I mean, all of these things can be very traumatizing, but the more that we can support our patients with pain management and appropriate language in this context, the better their outcomes, psychological outcomes and recovery, hopefully will be. In our emergency department, we do see a number of patients with pregnancy-related conditions, especially in first trimester, who have told us that they feel unsupported. In first trimester, they often feel that they don't have a healthcare provider that they can reach out to in an urgent setting. So we developed a website called pregnancyed.com that you can access. It has great resources about what to expect in the emergency department while patients, particularly those who are having long waits in our emergency department, but also describing early pregnancy complications and what to expect in the context of miscarriage and loss. The PDFs are free and are translated in English and French and can be downloaded and given to patients. But in our department at triage, we actually hand them these cards that have a QR code such that they can receive some information for the patients who are stable, of course, while waiting to see a provider. So just to review, the 4 T's of pregnancy-related hemorrhage are tone, trauma, tissue, and thrombin. And the management of these patients is about TXA, tone, transfusion, and temperature. So remembering to give those first and second doses of TXA, ensuring that the patient in the immediate postpartum period, if they're having hemorrhage, we have attention to the uterine tone, transfusing these patients when needed, and maintaining their core body temperature to ensure it doesn't induce a coagulopathic state. And then importantly, especially for those first trimester and second trimester losses, as well as for the patients in the postpartum period, we need to examine the cervix for potential tissue that's causing increased hemorrhage in this setting. So I just want to say thank you, and thank you to Anton for another great year at EM Cases Summit. And I look forward to seeing you all next year. Take care.